I'm going to be talking, like you said, about current and also future uses of predictive analytics in our everyday spine practice. No real relevant disclosures here. So I'm going to talk about how we use predictive analytics to select patients for surgery or can use them, plan our alignment goals, use these technologies in the operating room, and then also monitor patients after surgery. So I would argue that patient selection is probably the single most important thing we do as spine surgeons. I think in a lot of ways, this really boils down to picking patients who are actually going to benefit from the surgeries that we're doing, and then trying to, as much as possible, anticipate or avoid situations where we have complications that are either just harmful or actually mitigate any benefit that we give from our surgeries. And I think, we've all probably seen, a million papers trying to predict some clinical outcome, some functional outcome from a spine surgery. And so I'm just going to try to highlight a couple of papers and a few, I think, key ideas about where we perhaps have some strengths and weaknesses and where I think we can do better over time. So here's a study that some of you may have seen published in JAMA Surgery from around 2018, about 2,000 patients. They were trying to predict functional outcomes, patient-reported outcomes from essentially a pretty diverse range of lumbar spine surgeries, all kind of 4 levels or fewer. And they had a few different models, but this was one of their models for ODI. And basically, you can see the variables they used are probably things that we're all very familiar with: demographics, insurance status, some general descriptions of the type of pathology like spondylolisthesis and baseline severity data, but really nothing, I would say, sort of particularly granular beyond that. And the models did okay, and they've been validated externally. And so this is actually some data from an external validation of that study. And so I know the numbers are a little small to read, but basically their discrimination of how they could discriminate, who did better and worse, was kind of so-so. C statistic around 0.7, which is kind of in the moderate range. And the graphs here are showing calibration plots, so how well the predicted outputs on the x-axis match the observed event rates. And again, you can see the fairly notable discrepancy between the two, again showing that while these models weren't terrible, they weren't excellent. A somewhat similar study from a few years later, about 2 years ago now, tried to do something relatively similar, but had a little bit of an easier task, just looking at lumbar discectomy, so much less diverse population, easier task, larger population, so almost 23,000 patients compared to only about 2,000 in the other study. And again, much more narrow focus, which is a much easier prediction task. And so here, the models did better. So these are the calibration plots, but the discrimination was in the roughly 0.8 range for the model. So a notable improvement in the discrimination, still not perhaps the best, but a lot better. And the calibration in terms of this relationship between predicted and observed outputs were definitely better. So I think some basic takeaways that if you have a simpler problem, right, if you have lots of patients trying to predict one outcome, especially in something like lumbar discectomy, which is fairly homogeneous, it's an easier task. More patients tend to yield better outcomes or better prediction outcomes. And also, perhaps the use of more advanced modeling techniques with different machine learning models may have helped as well. But even in this study, the types of predictor variables that they used are really the same sorts of variables: demographics, comorbidity status, prior surgery, smoking, opioid use, things that I think we all think are relevant, but are really the same types of things that we're thinking about every day. It's almost the sort of common sense stuff that we're thinking about when we see a patient in clinic. Slightly different note, but same idea. Here's a validation study conducted from the ASLS data set, but of a complication prediction model created by the ISSG. And basically, the predictions did not do that great. They're better than chance, but the discrimination or C statistics were mostly in the 0.6 range, so really sort of modest at best. And again, I would argue that probably the most notable thing are the variables that were used as inputs, right? Basically things related to the degree of deformity severity, the degree of surgical invasiveness, and then some basic sort of demographics like age, but we're really not capturing really detailed characteristics of what may make one person more or less vulnerable to a complication than someone else. And so this is really the only plug I'm actually going to give for kind of my own research. But one of the things that we've done is trying to less so, I would say, add more advanced analytics, but more so add hopefully better predictors. So we did a study in about 150 patients where preoperatively, these are all lumbar thoracolumbar surgeries. Patients completed brief momentary questionnaires called ecological momentary assessments or EMAs, where they would answer in real time how they felt in terms of their pain, mood, things like that, multiple times a day over several weeks. And then they wore Fitbit monitors to look at their activity, their heart rate, and sleep. And we sort of derived a number of different types of variables from these data and used those to predict different types of functional outcomes 1 year after surgery. And I would say the key takeaway is that diverse and sort of complementary data elements help. So, on the right is basically our traditional types of patient-reported outcomes and demographics and such, similar to what was used in the other studies. And in this relatively small data set of 150 patients, they did okay, but not excellent. As you add these complementary data sets, our prediction abilities get notably better, varies a little bit by what outcome, but do notably better. And interestingly, actually, for many of the outcomes, passive measurements just from Fitbit actually do better than our patient-reported measurements do. So not that we've sort of solved the problem. Arguably, these are not actually ready for prime-time clinical use, but I do think help to make the point that we need more and better data elements combined with larger data sets if we're going to have more actionable predictions. And so I think the future for patient selection is larger data, but really higher quality data using these types of diverse data elements that are really not present in most of the hundreds and hundreds of papers that have tried to predict functional outcomes from spine surgery. So shifting gears a little bit to alignment planning, I think we're all familiar with the concept of alignment planning. It's obviously critical for probably any spine surgery, but especially any instrumented lumbar thoracolumbar fusion. And we do have reasonable platforms for this, and I'm sure we've all seen things like this. And they're fine. They can help you plan and think about your goals. They have some predictive ability in terms of perhaps how the spine would compensate, though overall quite limited. And so we use these. We kind of have some surgery. We say we achieved our goals. We're happy. But this is, I would argue, a fairly primitive application of what alignment planning could be. It's really based off, somewhat limited data sets, really just looking at X-rays. And we haven't really gotten very far at all until looking at compensatory response to the spine. I think this is particularly relevant to degenerative surgery, the impact of bone health or muscle health, which we increasingly know matters, but are not part of these predictions. So I think that's really going to be the future and what's going to make this technology far more actionable for us. Intraoperatively, I think we are using these technologies, but it's going to improve. So right now, I think we're all familiar with robotics. The core of a lot of robotics and the registration we use is predictive analytics, computer vision, and segmentation. But right now, what we do, I would argue, is fairly simple, right? I mean, we use robotics to place screws, and that's good. And I mean, I use that technology, and it's helpful and nice, but it's not transformative. I mean, I can place screws a whole lot of different ways, even through open and minimally invasive approaches. I think those capabilities are going to really expand into things like minimally invasive bone cutting capabilities, and I think things like this maybe have a much bigger impact on what we can do intraoperatively. Similarly, right now alignment is really based off of preoperative planning, right? You make a plan and then you check an X-ray, and then at that point you can make changes, but it's slow and it's not great, and sometimes it's hard. I think that a huge opportunity is to actually be able to evaluate segmental alignment in real time, and I think that is very much on the horizon and is feasible using the same types of technologies that we're already applying. And I think that will have a really big impact on being able to achieve what we think are important alignment goals. Similarly, these same sort of segmentation technologies can take the X-rays, which we look at in the operating room routinely, allow us to actually evaluate our screw placement better for safety purposes. And again, another opportunity that I think is on the horizon. Post-operatively, a number of people, including John Yoon, a friend of mine, have done work on this. John has looked at using smartphone-based assessments to monitor recovery from surgery. There's commercial platforms that offer these abilities now, and there's reimbursement models, but there's a lot of challenges in terms of who's actually monitoring these. Are you being paid enough for this to be worthwhile? And perhaps most importantly, is this actually impacting your outcomes? So I think there's an avenue there for applications, but I think the jury's still out. I think there's lots of other opportunities I'm just going to gloss over, whether it be hemodynamic monitoring, neuro monitoring, or sort of video monitoring of the actual surgeries that we're completing, and perhaps those things are a bit further along. But big picture, I think, we are using predictive analytics. It is somewhat helpful today, but the potential applications, I think, are far, far greater than what we're doing. And I would argue that we're limited far more by, the data available to us than, the modeling capabilities. I think the modeling capabilities, while they'll improve, they're there and they're quite good. We need to really add, more high quality, larger scale, and diverse data elements so that we can ultimately achieve our goal of having happier patients.